Today, we celebrate the memory of an exceptional physician and surgeon, Dr. Gene Weiner. Dr. Weiner's career here at Children's began in 1972 as a pediatric surgical resident. And among his many contributions over the years to Children's, he had a lifelong interest in the treatment of children with cancer. His involvement included serving on the Children's Oncology Group, the nation's largest clinical research organization devoted to pediatric cancer. He received many research grants to investigate the aspects of pediatric cancer treatment and published extensively on surgical oncology, particularly Wilms tumor, and also vascular access, including more than 85 journal articles in his career. Gene played a key role in mentorship of many young physicians and surgeons, and also in the development and design of our location where you're sitting here today, the Children's location in Lawrenceville. He was the medical director of Children's from 2000 to 2006. He was truly a masterful pediatric surgeon. And on a personal note, actually, Gene operated on my cousin, Tim Saber, in the late 1970s, when my cousin had lymphoma. His fantastic dedication to CHP lives on to this day in many aspects of our patient safety culture. He really, I credit Gene to really kicking off our patient safety initiatives here in the early 2000s, including the installation of computerized physician order entry, or what we called back in the day CPOE in 2003. Hard to believe that was 20 years ago in many ways, but I remember when Gene was a champion of that and bringing Cerner into the organization to improve medication safety and patient safety through physician order entry, made us the first pediatric hospital in the nation to do so. It was truly visionary leadership. Gene was also a mentor to myself when I was a young division chief. He gave me wise counsel when I was growing a division here, and when we brought the Cleft and Craniofacial Center into Children's Hospital, was wise counsel to myself and Dr. Joe Losi from Plastic Surgery. I'd like to invite Jeff Weiner, Gene's son, up to give a few words about his father. And I'd also like to thank Jeff that this is the 17th year that Jeff has chosen to be with us here to celebrate Dr. Weiner's career here at Children's. Thank you, Jeff.
Morning, everybody. Let's see. Yeah, it's been 17 years since we had the award created, and want to thank Children's, of course, for keeping his legacy going for this long and hopefully for many years to come. It's always a great honor to come here and witness the event and speak in front of everybody, and just hope that his legacy and the idea behind this award lives on. It's basically just to recognize someone who goes well beyond the job of healthcare and makes it something that's they realize how important it is, and especially since we're dealing with children. And they don't really usually have a voice other than their parents and the people that are taking care of them. So again, just want to say thank you to Children's, and hope we have a wonderful lecture as always. Thank you.
Thank you, Jeff. I'd like to thank the staff and everyone who submitted nominations for this year's Eugene S. Weiner Award for Excellence. And I'm incredibly pleased to recognize and honor Dr. Peter Davis as this year's award winner. Dr. Davis really embodies, anyone who knows Peter Davis knows he embodies the spirit of this award through your lifelong commitment, your lifelong commitment, Peter, to the care of children. I remember early in my career here, you espousing something in the operating room about being a pediatrician first. And I think your tireless advocacy, voice, perspective, And really the way in which you've conducted yourself your entire career here is exemplary. I know all of us are honored, those of us who work here at Children's are honored to stand beside you and are humbled by your gifts and what you've given over the years. I'd now like to speak just a few words about Peter, what you've done. During your 20-plus year tenure as our anesthesiologist in chief, you've led our division to become one of the top programs in pediatric anesthesiology nationally. Those of you may or may not know this, but he is a household name in pediatric anesthesiology. Your Smith's Anesthesia for Infants for Children is the standard mainstay, much like our Zitelli Atlas is for pediatricians. It's in its 10th edition now, and the book has been translated into many languages, making your impact truly global. The breadth and scope of that book is really allows it to be the gold standard. And we're also fortunate to have many contributors. Those of us at Children's have been asked to be contributors, including Dr. Sylvia Choi, Dr. Michael Moritz, Demetrius Ellis, and Basil Zitelli have all contributed to your book. You're deeply committed to improving care for the whole child, also through your training efforts. Generations of pediatric anesthesiologists have been trained under you, Peter, and have taken on the advocacy and the passion for excellence in patient care, which you espouse. One of your nominees wrote, quote, "Our job," this is something you said to them, "our job is to train you to take excellent care of children wherever you might end up in your career. You can be in the middle of nowhere or at a major academic institution. We want you to be able to provide excellent care to any child you come across." Peter, I could go on for many minutes speaking about your contributions here at Children's. There is no greater honor than to present you with this award. I'd like to invite you to come up and please say a few words.
Thank you very much. It's a privilege to be able to accept this award, and it's a privilege at a number of levels. Number one and foremost is that I happen to be one of the few remaining people at Children's that can actually say I worked with Gene Weiner. Both of us were in the operating room, lots of nights, lots of days, each on the other side of the ether screen, I on the right side, Gene still dealing with the fact that he was on the wrong side of the ether screen. But nonetheless, I think the both of us basically benefited from each other's expertise and knowledge, and more importantly, our patients benefited from it. Whenever we would get into a discussion, we basically came down to the bottom line was what's in the best interests of the patient. And I think that's been my guiding light in all of this. As an award recipient for a patient safety award, I think it would be somewhat naive of me to think that this is really about what I have done in terms of patient safety, but really what the specialty of anesthesia has done for medicine in general in terms of patient safety. One of the things is being somewhat older. I grew up in an era where childhood polio was the thing that basically scared families. Death from polio was not insignificant. And the vaccinations were just coming out. So it was back in the 50s and 60s, it was like a form of the plague in some ways in families. And what was more interesting was when I went back and looked at the statistical analysis of patients throughout the country, death from anesthesia was 10 times higher than it was from polio. And it was astounding to think that over the last 60 years, that incidence has been reduced in terms of anesthetic mortality to something that occurs between 1 and maybe 2 in 10 to 20,000. And so there have been great gains in that. And through anesthesia, not through me, but through other smarter people like in anesthesia, technology has vastly improved safety outcomes with regards to monitoring, the ability to measure, and the like. And so in a way, I'm humbled by this award, not because it's me that's done anything, but really I've been fortunate to have a education in groundbreaking work in terms of my pediatric background as a pediatrician. I even can claim that I was chief resident in pediatrics before I went into anesthesia, and I did critical care when I was initially starting out as both a dual boarded pediatrician and anesthesiologist. So I accept this award, not so much for me, but on behalf of my department and my specialty. And I thank you all very much for the work that you do. Thank you.
There's not a more classic Peter Davis acceptance speech than that. Immediately deflect all of the credit and spread it across the entire specialty. Thank you. Thank you, Peter. I'd love to, and I'm honored actually to introduce our lecturer for today, Dr. Anna Six-Samuels, who is going to speak on improving care through diagnostic stewardship for hospitalized children. Dr. Six-Samuels is an assistant professor of pediatrics at the Johns Hopkins School of Medicine and an associate hospital epidemiologist in the Department of Hospital Epidemiology and Infection Control at the Johns Hopkins Hospital. You also attend as a pediatric infectious disease consulting physician at the Johns Hopkins Children's Center. She conducts clinical research to develop effective strategies to prevent healthcare-associated infections and multi-drug resistant infections in children. She investigates how diagnostic stewardship of microbiology testing can optimize testing, treatment, and quality of care for hospital children, with a particular focus on the Bright Star Respiratory Multi-Center Study to improve respiratory culture practices among mechanically ventilated children. Please welcome me in joining, please join me in welcoming Dr. Six-Samuels.
All right. I'm a little short. Good morning, everybody. Can you see my face? Oh, good. Okay, good. So it's such a pleasure to be here. Thank you so much for inviting me to be here. I was a resident here, and I'm seeing some wonderful, friendly faces and some new faces I've yet the chance to meet. So really, I'm just excited, and it's a pleasure. Thank you. Today, what are we talking about? We are talking about, and this is the theme throughout all of the work, how can we optimize patient outcomes to avoid patient harm and standardize clinical practices? And this phrase and this question I put forth is not specific to my specialty. It really is a broad one that is applicable to all of our specialties throughout pediatrics, throughout adult medicine, really through the continuity of care everywhere in medicine. And so I appreciate how, when we think about patient safety, sometimes we don't always think about what are we doing to the patient that might put their safety at risk, because we always come in wanting to help patients, but sometimes do we do things that might actually unintendedly harm them? And so this is the question, and we'll come back to these thoughts as we talk today. I don't have any interesting disclosures, but I do have some grant funding that does fund the work I'm presenting today from NIH, HRQ, and the Donahue Foundation. Our objectives are to understand the potential harms of overuse of microbiology testing, to identify opportunities for diagnostic stewardship to improve patient care in hospitalized children, and learn how the Bright Star Collaborative has applied quality improvement, implementation science, and human factors engineering to improve culture practices. All right, so what is this term, diagnostic stewardship, that I'm saying? It's the judicious use of microbiology testing to inform safe, effective, and efficient patient management and treatment decisions. It actually came out of the concept and field of antibiotic stewardship, which has the kind of global aim to reduce the risk of antibiotic resistance, which is a global threat and a threat to all of us individually and for our patients. And so even though it came out of antibiotic stewardship, it's actually a little bit earlier in the decision-making process. So clinical care is not always linear, but in general, we kind of follow this pattern of we have a concern, so we send a test, which helps us make a diagnosis that informs what treatment we prescribe to hopefully get the optimal patient management. Antibiotic stewardship focuses on this prescribe the treatment step, while diagnostic stewardship is a little earlier at the time when we're sending the test. So it has the ability to impact all the things that come after that, including our antibiotic treatment decisions as well. So why do we care? What is the harm from over-testing? So I'm going to make this specific to infectious diseases here, but there are microbes everywhere. There's microbes on our skin, in our gut, in our throat, everywhere you touch, the air. So if we go testing for them, we may very well find them and identify them. If a test is positive, that reflects that an organism was detected. It could lead to false positives. Why do I have this in quotation marks? Because we might interpret that test as reflection of infection in the patient, but it might just be that an organism was detected somewhere between the sample that was collected and the result of the test. So it's true, it's not false, it just may not actually be reflecting infection. And when it's not reflecting infection, that leads to avoidable antibiotic treatment. That leads to repeat testing to confirm if it was a positive test, and those things increase the length of stay for the patient. I like the example of a baby coming in for evaluation of fever to the ED. They otherwise look well, they meet criteria to go home, likely have a viral infection from their siblings, and 36 hours, 48 hours later, their blood culture that was obtained is positive for gram-positive cocci. That family is called back. They are worried. They're told their child might have bacteremia. They come to the emergency room. The child's restuck, started on vancomycin, and orders are placed for admission to the hospital. At this point, the result of this test now comes back several hours later that it is coag-negative staph. The child has no risk factors for invasive coag-negative staph infection. This very likely is a skin contaminant. And now you have to decide whether you reverse the entire process and send this kid home, or you follow through because you've already made this family super worried that their kid's very sick. So we have real life scenarios where we're dealing with this constantly. Excess antibiotics promote antibiotic resistance. This is an important thing for all of us to keep in mind. 40% of our hospital-associated infections are now antibiotic resistant. Antibiotics are not harmless. 1 in 5 children will have an adverse event to an antibiotic. That is not harmless. Hospital performance, slightly different take, but those false positive results can also increase some of our safety metrics that we follow really closely. CLABSI rates, C. diff acquisition in the hospital. And that is important because people might judge what hospital they go to based on their interpretation of safety at that hospital. Reimbursement might depend on some of these metrics. So again, it does matter. Back to the patient and the clinician, cognitive bias. We all are at risk for cognitive biases. One of the ones I like to point out with testing is anchoring bias. So if we get a test result early in a patient's clinical course, we might anchor our thoughts, our differential diagnosis on that test result and kind of not pay as much attention to what happens later or what additional information we get. One of the examples I give is a patient with a tracheostomy who came in with a fever, not well, and sputum culture was obtained from their tracheostomy that grew some bacteria. They were treated for that and sent home. They represented later in the week, still febrile, very sick, found to have a perforated appendicitis with abdominal abscesses. We missed that. We missed the real cause because we were focused on this trait culture. All of these things increase the costs of care. And if they're not improving the patient's outcomes or they're even making them worse, that's the opposite of high value care. So this term, high value care, you may have heard of it, but it's a nice goal. It also is related to the Choosing Wisely campaign, which is a kind of national effort to try to be more judicious about our testing and interventions. It's balancing the risk of a possible harm of testing and treatment and trying to reduce costs of care against trying to provide actual clinical benefit to the patient and improve their outcomes. So these are the two kind of factors that balance. Applying it to stewardship, can we safely test less? And if we do test, can we do it better? So I had the pleasure of being on a national task force here to think about diagnostic stewardship. And we basically ranked the goals of diagnostic stewardship. And so these are presented in priority order. So the first is to improve patient care and outcomes. The second is to avoid patient harm, then optimize antibiotic use, improve efficiency of care, and those costs and metrics that I talked about. So all those things kind of in reverse, but really it's about patients. All right, diagnostic stewardship. What are the targets? How do we actually implement diagnostic stewardship? Where do we think about it? The first step is, do we get a test? So that's a clinical decision. The second step is, okay, I decided to get a test, and usually in infectious diseases, that means we need to get a sample from the patient. So how are we collecting that specimen? Here I have the example of sputum versus saliva. Are we collecting sputum from their lower airway, or did we catch some saliva from their oropharynx? And so depending on what we collected, that's what our test is going to give us at the end. Now the test goes to the laboratory and it's processed. There's choices here. What platforms is it run on? Is it a molecular test? Is it a culture-based method? What's the turnaround time? And then there's results. How do we report those results? Again, there's choices here. In the example of respiratory cultures, we can report a quantitative result, 1,000 colonies per ml, or a semi-quantitative result, 3+ or medium growth, or we can just give a binary result, positive, negative. These are choices. All of these things influence how we interpret that test and how we decide whether or not we're going to treat that patient. So as we keep talking today, I'll reference back to this slide and these concepts of the different targets. All right, so let's start with that first step, the clinician. So what can you ask if you're trying to decide to get a test? And now I'm going to make it specific about ID. Does the patient have signs or symptoms of an infectious process? Or can another process better explain these symptoms? What is the optimal diagnostic test available to me to evaluate for this infectious process? And a mention to the trainees out there right now, you're at CHP. You may very well graduate and go on to somewhere else. And guess what? The testing options available to you will change. So get familiar with what is available to you and which test you should be sending based on the setting you're in. And how should the sample be collected to optimize those results? Traditionally, back in the day, doctors collected all their specimens. That's no longer the case. Often someone else is collecting specimens for you. And so it's worth asking, how is that specimen obtained, and getting a little bit of that detail so you understand what's being tested. I'm going to get a little more focused now and talk about some examples. I'm going to start with the history of diagnostic stewardship at Hopkins and then kind of where I got involved and go from there. So in 2014, nearly a decade ago, a group of folks decided there was way too many blood cultures happening in the Johns Hopkins Children's Center PICU. And they were actually worried that it was, they were detecting a lot of false positives and patients were getting treated for bacteremia events that were likely not real. They came up with a clinical decision support tool with a checklist of things to think about and an algorithm to guide when and what kind of blood cultures to get. That led to about almost a 50% reduction in the blood culture rate coming out of this ICU. Clinical outcomes showed no increase in sepsis, septic shock, mortality, length of stay, or antibiotic use. That's a really big reduction of bloodletting. So Dr. Aaron Millstone and Charlie Woods-Hill, who were part of that team, had the foresight to say, well, what if we expand this? So they actually reached out and started the Bright Star Collaborative. 14 hospitals got together with the, Bright Star stands for Testing Stewardship to Reduce Antibiotic Resistance in Critically Ill Children. And so the goal is to use clinical decision support tools across multiple hospitals now to see if this was, if they could replicate it again, if other hospitals could do this, and also to look at the safety when it was scaled up. So this was published last year, but across these 14 hospitals, there was about a third reduction in the blood culture rate. There was no changes in mortality, length of stay, readmission, sepsis, severe sepsis, shock. And they did see now a reduction in broad spectrum antibiotic use and also antibiotic initiations. I don't have a bullet here, but there was also a reduction in CLABSI. They've further investigated that, and it's not, the data's not kind of prepared yet, but I can just anecdotally tell you that it shows that there was a reduction in CLABSIs in these hospitals as well. All right, so that was blood culture. So that's where it started. When Bright Star Blood was active, I was a fellow, and I was getting the pages for the children who had trach cultures obtained and were growing multi-drug resistant gram-negative organisms. And the ICU would call and say, how do I treat this? And at that time, we didn't have some of these newer agents like Miraviber and stuff like that. So we had to use colistin on some of these patients. And one of the patients I cared for at some point actually had a real pneumonia, and she was on everything we had, colistin, meropenem, aminoglycoside. She was going to die from this infection. And so we threw everything on her. And then she got acute kidney injury and she went on dialysis. And when you look through her microbiology history, she had dozens and dozens of tracheoaspirate cultures, and she had been treated for most of them. So we created this impossible to treat organism as a healthcare system. And it really made me take pause and say, we could do better. Just in case you're not familiar, what is being cultured when we get a tracheoaspirate? So this young patient on the side, she has a tracheostomy. So the tube's going right into her throat, and there's a plastic tube there. And so there's a little catheter in the plastic that would go through and suction some stuff out. And that's what we send for culture. If you have an endotracheal tube, the tube's going through your mouth, ending in your trachea. And so it's going through the mouth space, through the back of the throat, down into the trachea. So these are not, these spaces are contiguous with the outside world and with our mouth that, by the way, is pretty dirty. And so they're not sterile. Endotracheal cultures are ripe for diagnostic stewardship for a lot of reasons that I hope I can convince you on today. But in summary, positive cultures don't mean the patient's infected. We as clinicians are inclined to treat positive cultures though, and that leads to overtreatment with antibiotics. And there's a total lack of standardization around ordering, collection, and processing of these samples across the country. So the first point, the respiratory tract is not sterile. There's bacteria there. So if we go looking for them, and honestly, if the culture is negative, I would take pause on the sample collection because there's bacteria there. And whether those bacteria reflect just bacteria being there or those bacteria causing invasion, inflammation, and illness in the patient, that culture can't tell you the difference. More than 50% of cultures, just general clinical cultures, will be positive within days of intubation, irrespective of the patient's symptoms. And then once those bacteria get on the plastics, they make a biofilm that antibiotics don't really penetrate. And so bacteria persist despite being on appropriate antibiotics, just because the drug can't actually reach the bacteria. So some wonderful folks, Dr. Doug Wilson, who's now retired, but as a senior ICU clinician, started the VANE studies, so Ventilator-Associated Infection Network. And this was a prospective international multi-center cohort study where they looked at the general approach to ventilator-associated infections, and they found that antibiotic treatment was significantly more likely after a patient had had a positive culture result, but that wasn't associated with improved clinical outcomes in the patients. They followed up to say, okay, well, maybe we can find a way to standardly de-escalate antibiotics in patients that are doing okay. And so they came up with a consensus treatment guideline, but only 27% of the folks in this study actually de-escalated the antibiotics per guideline. And typically, or the most often cited reason, was because the patient had a positive culture. Positive cultures were not associated with the patient's symptoms nor their outcomes, either in the first vein study nor the second. Ordering practices. So I got to work with Andrea Prinzi, who's a microbiologist in Colorado, and we did this study together, which was pretty fun. So we reached out to the Pediatric Health Information System, PHIS, which is a national database of, it is billing data, right? So it's data that hospitals submit to PHIS. And we had the question of how variable are endotracheal culture practices across the country. And 31 hospitals had a good enough data to do this. So that included 40,000 patients, 80,000 cultures. The mean rate was 46 cultures per 1,000 ventilator days on the hospital level. In an adjusted model where we considered patient level factors like duration of intubation, chronic conditions, severity of illness, these types of things, whatever we could adjust for, we did. There was still a 10-fold difference between the highest and the lowest rates of culture use at the hospital level. And we took it one more step further to say, is there any association, still keeping all these adjustments, with antibiotic use? And basically, if a patient had a respiratory culture, they had a nearly 3-fold odds of additional antibiotic days of therapy. So at a national level, there's variable practices across hospitals, not just within hospitals, and that does perhaps influence antibiotic treatment. All right, I'm still marching down the diagnostic stewardship targets here. So collection methods. So that's the ordering differences. There's really variable collection methods, and the samples might be inadequate because we got saliva. Saline lavage. Across our Bright Star hospitals, most hospitals are actually using saline lavage, meaning they squirt some saline down the trachea and then suck that out and send it for culture. That dilutes the sample and you don't really know what you're getting there. And one more point here is the inline versus new suction catheter. If you use a new suction catheter to collect the specimen, you get a lower bacterial count than if you use the existing inline. And that makes sense because bacteria have had time to kind of collect on the plastic. But if you're using the quantity of bacteria to inform whether or not you're going to treat that patient, it really matters how the sample was collected. And now processing. So Dr. Prinzi did this study. She surveyed 73 pediatric clinical microbiology labs across the country. 77% had no rejection criteria. There is variable gram stain parameters and objectives used when looking at gram stains. That matters. If you look at this slide, let's say you used the 100x objective, but you zeroed in on the part with lots of bacteria, you might say many. Well, if you zeroed in on the parts with few bacteria, you might say few. So the same sample sent to different labs using different approaches to process these samples very well may have different results. And reporting. So, and by the way, Andrea did a whole PhD on this stuff. So this is her collection of work. So she then further took this one more step and said, well, what about how we report specimens? And there are guidelines. So the American Society of Microbiology does have guidelines on how to do this. And you have the option, if you see lots of different bacteria, to report mixed upper respiratory flora. But some people will subspeciate those mixed organisms and give names to them. And so she looked at what the antibiotic prescribing was after that result came out. And what she found, again, doing trying to control for things with a multivariable regression, was that over-reporting, meaning giving the species names, was associated with 3 times more antibiotic days of therapy than mixed upper respiratory flora reports. So this suggests that we as clinicians are influenced by what the report is showing us. If we see a bacteria name, we might be more inclined to treat the patient than if it just says mixed bacteria. All right, so back to Hopkins. All of these problems existed basically, and I decided to go learn more. So every time a respiratory culture was ordered, I would go and find the first call clinician and ask them why they sent the culture and what information they were hoping to get from it. It was a formal survey. I recorded it. And then 3 days later, I would go back and ask the team, well, what did you do with that culture information? What's the patient's diagnosis? And, was it helpful to you? And I learned things. There was 2 drivers. Either the patient had a fever or there was a report that the secretions were funky. And so those were the 2 main reasons cultures were ordered. Many of the cultures were not helpful or just totally ignored afterward. Or people were not even aware that the patient had a culture sometimes. And so we could do better. And so we came up, a group of us, ID, ICU, microbiology, respiratory therapy, came up with this guideline. And because secretion reports were such a prominent thing, that's actually why secretions are at the top of this. I'll show you how it's changed over time. And then let's make sure the patient has at least some other symptom of a ventilator-associated infection. So secretions plus something. And it's been more than 3 days since the last culture because really data repeated within that time doesn't really show additional information. And we also worked on specimen collection practices. So we had 3 targets here: clinical decision-making, the microlab, and specimen collection. This led to about a 40% drop in our culture rates in the ICU. It also reduced our repeated cultures within 3 days. We had no change in clinical outcomes, mortality, hospital length of stay, those things. And just on averted cultures, we saved $26,000 a year. I can say this was sustained and it's been improved since, which we'll see. At the same time we were doing this, some colleagues in Boston Children's were doing essentially the same thing. So they came up with a clinical guideline that addressed clinical decision-making, specimen collection, microlab practices. They added antibiotic treatment recommendations. They saw also a wonderful impact. So 34% decline in cultures. They looked at some nice outcomes. There was a 71% reduction in ventilator-associated antibiotic days, so a different way to measure antibiotic use. And they saw no change in ventilator-associated events or the duration of mechanical ventilation. So nice specific outcomes there, which were relevant. So Bright Star Blood, if you remember me talking about it, was wrapping up. So here were 14 hospitals that had just done stewardship of blood cultures, and these data were coming out. And so we pitched it to them and we said, would you all be interested to do a part 2 and now do stewardship of respiratory cultures? And that's how Bright Star Respiratory got started. Again, for the budding academics out there, I want to just share some of the experience. So this was now in early COVID, and we put together over 7 major grants. So like 100-page plus type grants, Ks, Rs, foundation grants. And they weren't getting funded, and it was sad. And and then something happened and 3 grants basically got funded at once. So now we have 3 grants supporting the work, and it's really wonderful. These are all our collaborating sites, and it's such a pleasure to work with them. It's made it so fun. I love meeting with everyone all the time. And you guys will notice a familiar symbol on this screen. So we are excited that CHP is one of our partnering sites with Zach and Glenn here. So what are our goals with this project? We have a lot of goals, and I actually kept the list shorter than the full list. So first, we're going to understand our current practices. We want to improve those practices. We want to evaluate the impact on culture use, antibiotic use, and safety. We want to develop some consensus about what we should be doing. We actually are holding a meeting in a month to develop national consensus guidelines. And we also want to inform how we can implement this effectively, because it's not good enough to have a guideline. You need to know how to do it. And so we are studying these implementation science type questions along the way. All right, so I'm going to start sharing some results. These are all separate studies here. So We did a survey of respiratory culture practices across the Bright Star group. And what we found, I'll give you a little more background. So this was for healthcare workers at all of the participating hospitals, and we sent it out to docs, nurses, and respiratory therapists. And we asked a whole bunch of questions, and they would say agree, disagree, and a Likert scale. We grouped agree and strongly agree. And then we collapsed what was the percent agreement within a site? Because we were really interested in the practice variation across sites. We knew there would be practice variation within a site, but we wanted to see the trend across hospitals. So a total of 16 ICUs participated, and we had over 550 responses, which was incredible and well over our anticipated goal. This included fairly large ICUs, 34 beds was the median. About a fifth of the patients are ventilated. Does represent some cardiac surgery, ECMO, BMT, and solid organ populations. Experience was decently represented. Understandably, lower experience was a little bit more common, particularly among nurses. Doctors tended to have a little longer experience. So I'm going to kind of talk through this because it is a lot on one slide, but we gave various little mini vignettes on how likely do you think a respiratory culture would be obtained for these various clinical scenarios in your ICU. And you would kind of rank it. And so there was some that we anticipated should be at the top of the list as very likely. So if a patient had a new fever, a new increase in ventilator support or oxygen demands, we anticipated most sites would be likely to get cultures for those patients. And indeed, that was at the top of the list, very likely. In the middle, and this is where I was most interested, is what was variable across hospitals, where some hospitals were doing it, but other hospitals weren't. And so change in color or thickness of secretions without other symptoms, new fever and lab changes without respiratory symptoms, increased volume of secretions without other symptoms, new lab changes alone without other symptoms, or just new fever alone. And so all of these are a little bit more non-specific indications, which is interesting. So we took this another step further and we said, is there a relationship between some of these testing practices and the rate of culture use at that hospital? And I don't have a slide on it, but the rate of culture use across the Bright Star hospitals was exactly reflective of the FIS data. There was a 10-fold difference in the rate of culture use from our lowest to highest user hospital. So a lot of these variable practices ended up correlating with culture rates, meaning if that site was more likely to do that order cultures for those indications, they were more likely to have a higher hospital rate of use than the opposite. So persistent fever, new fever alone, fever and secretions, pan cultures. So if hospitals have a practice of doing a pan culture in response to fever, they were more likely to have a higher rate. And then new hypotension without respiratory symptoms also is on the list. And then something that initially surprised me, and then debriefing with our ICU colleagues, many of them felt it didn't surprise them. So there was other questions in the survey, and two that also correlated I would find a decision support algorithm helpful. This had inverse correlation, meaning that the hospitals that would find it helpful had lower rates of use, and the hospitals that wouldn't find it helpful had higher rates of use. A decision support algorithm would help align the ICU team or consulting teams. And again, hospitals with lower rates of use thought that would be the case. So that was kind of interesting. We asked about anticipated barriers to changing practices at their hospital. And the ones that came at the top of the list were reluctance to change, the opinion of consulting services, and that clinicians may not change practices because of concern for missing a diagnosis of ventilator-associated infection. Things like workload, not enough time, difficult to review the EMR data, those things were not perceived to be barriers. So what did we do next? Each of the sites got their own reports back to them, and the task was to develop clinical decision support to guide culture practices at their hospital. They didn't have to include the exact same thing, but I'll say just about all the algorithms look very similar and have similar content. And they could adapt it to their needs and their stakeholder input. So some had exclusion criteria, for example, and some don't. So here's our interim data. We're not quite done our follow-up period yet. So this is where we are so far. But at this point, it looks like we have about an 18% reduction in our culture rate across the collaborative. What you'll see here is demonstrated the wide variability in the baseline culture rates. And there's different factors that go into it. Things like whether hospitals are likely to get intubation cultures or not really influence their rates as well. So not just ventilator-associated infections that happen later in a course might factor into this. We were really concerned about making sure we monitored safety. This was a QI, multi-center QI, but this was something that we wanted to make sure was accounted for. And I can't tell you how many hours were spent debating safety metrics, but ultimately we just decided to ask, did you have any concerns? And so we asked our site leads to ask their colleagues, do you have any concerns about the algorithm set forth? And if so, what were they? And let's talk about it. So over 1,700 questions have been asked of attendings with a 92% response rate. Among all of these times, and because they might be doing it like once a month or once a week, depending on how the hospital's doing it. But 2 people have reported out of those almost 2,000 now that they had some concern a culture was delayed, but it didn't result in any patient harm. And in both of those cases, what was interesting, it was like a difference between the first shift and the second shift. So the first shift didn't get a culture, and then maybe something changed about the patient in the second shift, wanted that culture and thought that maybe there could have been some delay there. So they were a little equivocal on both, but we want to be very transparent. All right, so CHP, Dr. Rybczynski, Dr. Alderwald, thank you so much for being our site leads here. It's really so much fun. But here we go. This is your guys' decision support tool. It looks, fairly similar to what we've been talking about today. Signs of infection, signs of respiratory tract infection. Has the patient had a culture in the last 48 hours? And if not, maybe consider other things and some culture collection guidance. This is CHP's data benchmarked against this Bright Star Collaborative. So you'll notice our baseline rate here is quite higher than the average. And it took a little while for this to get going. COVID was going on, the triple-demic, if you will, last fall. I'm sure all of us can easily remember the many viruses circulating in children was going on. So there were some real challenges to doing this project, I'll say, nationally. But then things started to change, and I think that they have started to change. And so Glenn reviewed, and I think is still reviewing cultures, but he looked at kind of what was going on with adherence to the local guidance. And about 40% or so of cultures obtained were in the exclusion criteria here. And 29% that were obtained weren't aligning with the guidance. And they weren't aligning either because there was no sign of infection, no respiratory changes, or they were kind of close in time together. And then he went a little deeper. Of those cultures that were obtained that didn't align with the algorithm, what happened? 17 of them didn't grow any new information, so no new data was collected. And 5 did grow a new organism in blue, but the patients had either already improved or the antibiotic therapy addressing that particular organism was never added. And I think the easiest example here is Stenotrophomonas is often added, found again after someone's been on antibiotics, and it's less often actually causing infection. So that's probably some of these examples, I think. All right, and then since there's been some extending partnerships with QI, the microbiology lab, and perhaps EMR in the future, I hear EPIC may be coming. So what are some drivers and barriers? There's other people interested in this question, and one of them is an adult ICU doc, one of them is a peds ICU doc. And they both did something similar where they interviewed healthcare workers at their hospital to try to get at this question. And so the first looked at both drivers and then barriers to change. So in just speaking to people, they said increased identification of bacteria as a result of frequent respiratory culturing, misinterpreting the data, and fear of missing the diagnosis were drivers of overdiagnosis and treatment. So these are themes we're seeing again. And although healthcare workers rely on clinical and radiographic changes to initiate a workup, fear of missing a diagnosis was leading to sending cultures even in the absence of additional changes. In a PICU group, she found a group default practice. So there tends to be like a culture of practice that's just like the norm approach. Fear and also hierarchies in an academic setting were drivers. And barriers to standardization included, again, fear of misdiagnosis, tension between practice standardization and individual decision-making. I find this one interesting because this doesn't apply just to this. This applies to any clinical guideline that we set forth. There's a tension between that autonomy as the clinician to say, I want to do what I think is right for my patient, and well, let's standardize care such that if the patient comes to you and you're on service today or your colleague's on service tomorrow, they're actually going to get similar care on both days. And so our care is not so different from one another that what we do for them is so different. But as clinicians, this is a real tension for many of us. There's some folks thinking about this also from another perspective. So implementation science is basically, well, I'll dumb it down in my brain, how I think of it, is QI on a large scale. So you're trying to do stuff on a broad scale. How can you adjust drivers and barriers across many different settings to get the same good outcomes? And if you're trying to take away something, if you're trying to reduce that intervention, it's called de-implementation. Slightly different than, like, let's say we're going to put a new diabetes screening tool out there. Now we're going to try to take it away. So de-implementation has different challenges than implementation. And one of those challenges is habits. We have these shortcuts and patterns of behavior in response to the same situation. And especially when we're stressed out or mentally burdened or just have decision fatigue, we tend to revert back to our habits or those kind of routine practices. And I like the example here, the pan culture in response to fever. I don't know everyone in the ICU right now. I don't know everyone's risk factors. I'm just going to do the same workup for everyone because I know I'm not going to miss something that way. A suggestion to how to address this is to short circuit that habit and replace it with something else. So instead of getting a pan culture, ask the question, does the patient have any respiratory symptoms? And then you kind of add one little part and maybe interrupt that. All right, another issue, asymmetry of outcomes. So this is the risk or fear of missing that diagnosis feels more consequential than the risk of the harm that comes later from over-testing. So the fear of missing VAI in this patient today feels more consequential to me than what's going to happen if, you know, they get MDR and their next VAI episode is harder to treat. And so the suggestion here is to increase knowledge of harm from the low-value practice, review and provide feedback, highlight stories where patients were harmed from that low-value care. And so, hey, pointing out, you know, patient Smith was tested and received that extra antibiotic, but that led to acute kidney injury, and that extended his length of stay. Those are real harms too. A third one is psychologic reactance. And this is the negative response if I feel like the rights are infringed, which can fuel anger and mistrust. This one is prevalent. Think about masking for COVID. Folks who were mandated to mask, some people really had this feeling, you are mandating me to do something, you're infringing on my right, and that actually makes me not trust you as much. And I don't trust your medical judgment as much because now you're making me do this. And so it also applies to vaccines. So a suggestion here is to engage stakeholders early and then re-engage them to get feedback, hear concerns, and again, provide stories. In my mind, when I read these suggestions, it's relationship building. Form relationships with those people so that you can have a common ground and have some trust with one another. All right, let me do a time check here. Okay, so I'm gonna go a little quicker through the last part, but I wanted to tell you how things have evolved at our hospital, what we're doing now, and kind of what we're looking forward to. So we had the blood and the respiratory culture algorithms, and I'm sitting in a QI meeting, and one of our amazing nurse practitioners just goes, "Can we just have one?" And we all kind of paused and said, "Sure, let's do that." And it became a thing. So it was a formal QI work. We did look at drivers. I'm going to go through these a little quicker because I've addressed a lot of them today, but they were true at home too. So reflective practices, habits, cognitive bias, fear of missing infection. We had a complex patient population. Our ICU just sees everything and anything under the sun. And we have burn patients and surgical patients and cardiac surgery patients and bone marrow transplants. They all have different things. And that's a challenge when you're trying to standardize things. So how can you make it applicable? We have very complex team communication patterns, likely here as well. In an academic setting, you have so many layers of people involved, and each of those layers is like a telephone game, right? And so how do you get people to have a shared mental model? How do you get the pertinent information getting shared across those teams? And then existing tools weren't always being used. People weren't aware of them, or they didn't really like having multiple things. It didn't fit with their workflow. And then there's this clinician desire for autonomy that even if there is a tool, they may not want to use it at the end of the day. So this is what we came up with. I call it the rainbow fever algorithm. And it took about a year to put together, and we've had several iterations since it first was put forth. At the top addresses time-sensitive issues that really need prompt consideration and treatment. Then we also think about some indwelling devices. Then we think about everything else that could be causing a fever. And after we've thought about all those things, we think about urine studies. We got input from just about anyone we could get input from. We also had human factors engineering weigh in just for usability. We piloted it, and we continue to update the usability. This is the impact. Run charts of different cultures. Our blood cultures came down to about 17%, but I think more importantly, just the variability was a little bit in better control. Endotracheal cultures actually came down further. And so to point out, it's now fever plus respiratory symptoms is basically our guide. Urine cultures was new, and that had the biggest impact. So that was the first time we had urine culture guidance, and it was coupled with advocating for UAs first. And so those went up too. This is the same stuff, but in numbers. And then at the bottom, we also looked at antibiotic days of therapy and antibiotic initiations. We saw a 12% reduction in initiations, but no change in overall days of therapy. I think this was hard because we know our patient population got more complex between the pre and post periods. And we also know that we had an increase in cardiac surgeries, and some of those patients get antibiotics for weeks and weeks and weeks. So I could easily see how some courses could overshadow even reductions of courses for other patients. We looked at clinical outcomes. I mentioned we had increased complexity. The hospital length of stays went up a little bit. And when we dug into the weeds, what was apparent was just after the pandemic started, there was this shutdown of elective surgery. So we didn't have patients for short stay admissions. And we also didn't have a lot of those brief PICU admissions for asthma, for example. They just kind of went away for a year. So that post period included that time. And so I think there was some pandemic influence. There was no change in mortality. We reviewed every single mortality case and none seemed related. And we did see a decline in the PICU length of stay, which I found kind of interesting. I don't want to put too much weight on it, but I think it's encouraging that it didn't go up despite this intervention. We also asked for feedback. So we asked folks for feedback. We asked them whether they are using the algorithm, whether it helped them, and if they would change anything. It did lead to some positive changes. And I like some of these quotations, they're very validating. Appreciate the guidance. It gave us confidence to be more deliberate in our culturing practice. It helped me not forget anything, but also prevented me from over-testing when no clinical change had occurred. And we still have barriers too. We tried to use it, but other services insisted on cultures when the algorithm stated they were not needed. So that's real, that's just life. So now wrapping up, what do we not know? We don't know a lot of things. So would clinical decision support tools work in other settings? Are certain strategies easier and more effective? How much should we standardize? How much should we adapt to the local setting? Are non-clinician-based interventions more effective? For example, the laboratory hard stops versus clinician involvement with decision support. Does diagnostic stewardship of testing contribute to rare negative outcomes? It's important. We haven't had that indication yet, but I think we need to keep asking. And what about patient and caregiver preferences, especially if we move to the ambulatory setting? I think that comes in more. So to wrap up, diagnostic testing can result in unintended patient harm. Consider testing only if you have suspicion for the infectious process, and the results will inform your patient's management. Know what tests are available to you and what the optimal specimen collection is. Consider how to interpret the test before you send it. Medical care is complex and our patients are complex. And so just to consider what factors influence your own decision-making when you're getting testing. And I don't do any of this in isolation. I have a huge team of collaborators and they are all fantastic. So a shout out to many, many people here who are behind a lot of the work presented. Thank you so much.